Thank you, everyone. Thanks for having me here today, and welcome to Introduction to Health Services. This is a course that is taught over an entire module in LSHTM for masters and RD students. It's taught over 12 weeks. So I'm here for 5 days, and we're just brushing. Health services. We're all in the research of it, and we all know that it's a huge topic. We're sort of barely brushing the surface of the course, but I really wanted to give it an overview, and really through the seminars, through our time together, generate some discussions and learn from each other. And I'm very interested about the system in Japan. This course is taught for lots of students, international students in London, and so it's not specific to a country. It's much more conceptual and foundational, and the theories behind why we're working in the different systems. And actually you can apply country-specific examples, and it'd be really good to explore those as we go along together. So why are we studying health services? And I'm just going to put this slide up, I'll just let you read it. And you might find it's quite familiar. Perhaps you can already think of headlines in Japan as well, reading these kind of, these are all just headlines from different newspapers about health services around the world. And you're probably already getting an idea that actually, I can see familiarities. So, I can't read Japanese newspapers, but I wonder if you've got something similar, similar pressures in Japan. Any cuts, any difficulties in payment sources? A nod? No? Yes? Yes? Similar pressures? Okay, great. I think that is, we can really sum it up from that one slide, that we are looking for here in health services a simple but profound challenge. And why is it simple? Well, mainly I think all countries are trying to provide a high quality health system, healthcare, with the limited resources available. It sounds simple, doesn't it? But that's what we're all about. We want high quality, but it's also profound, because what does it mean? What does high quality mean? And also, limited resources available. We're always balancing against all, resources against the quality, against what we can do. And even if we think there are countries that have a lot of resources, spend 20% GDP, like America, on our healthcare, even then, when you are spending that much on your health, you are not spending it on something else. There's always a resource constraint. There's always a limit to what we can do. And also, what do we mean by high quality? Lots of people have probably heard different definitions of high quality. We probably, people use that term quite loosely, isn't it? High quality of this, high quality of that. So how do we define it? And there are many definitions. And in this course, I found to split quality into different dimensions quite helpful. And this is what we want to do. And first of all, I think high quality care should be safe. So Florence Nightingale in England many years ago said to do the sick no harm. So minimally, we want to go into health services, go into healthcare to come out no worse off than when we first started. So safe, one of the dimensions of quality. Secondly, effective. Many of us are looking at the effectiveness of care. What does that mean? Are we doing any good? To do no harm is sort of what we expect, and then we want to go into healthcare, come out better than where we are. So effectiveness. Now that in itself is quite loaded. We're going to explore more of that on the Monday talk when we talk about quality in greater detail. But essentially, it's doing some good. And the third dimension is humanity, humane care. So what does that mean to us? I mean, humanity is quite abstract, isn't it? It's not as automatically obvious, but it's a bit like beauty, or a little bit qualitative. But essentially, what humanity would mean is how you want to be treated. If you were the patient, how you wanted to be treated, mutual respect, dignity, those things. And in different places, call it different things. But humanity sort of encapsulates it all. In England, we look at patient experience. So that is a form of how the services, whether or not they're getting the food, the treatment, they're being covered up when they're being examined, and not exposed unless they are being examined, being treated with dignity. So that's humanity. WHO call it responsiveness. So they call it different things, but essentially is, if you were the patient, how would you expect to be treated? And so, very important. And these three are probably universally accepted as dimensions of quality, of high quality care. And then there's a fourth one, which is equity. And equity is fairness. What do we mean by equity? Essentially is, we are hopefully being looked after based on our need for healthcare rather than any other social dimensions like our sex, our gender, our age. Essentially is that. But, just to be mindful that actually equity might not be something, it is contested, it's not a given. There are countries where it is absolutely within the political and value base to have richer people should have better care. I mean, this is not universal. A lot of social democracies, we feel that actually it should be based on need. But it's interesting, isn't it? So we might all have a feeling about equity for other things, but should we all be allowed to have, big houses, or actually is that not equitable? But actually, when it comes down to health, we probably feel that actually, regardless of a lot of those social dimensions, everyone should be allowed fair access to healthcare, fair health services. And then finally, increasingly in the debate, there's sustainability, and this is quite, not as advocated as the other thought up to date, but I think slowly the rhetoric is changing and increasingly becoming more important in the agenda. And what do we mean by sustainable? Not only financially sustainable, but moreover environmentally sustainable. Now, there's very few research in this area to date, but increasingly we know that it's important with the climate change agenda. Health service activities does cause quite a lot of carbon. If you think about all the transportation journeys, all the treatments we give, all the personnel involved. And this, last year, the NHS in England, National Health Services in England, published a long-term plan. And it's one of the first times that NHS has published a plan, a strategy for the government. And in it talks about reducing carbon emissions of the activities of healthcare. And it really is really increasingly important that we think about the environmental impacts healthcare has. And I think there is some figures suggesting that in the United States, it's about 7 to 8% carbon generated from the activities of healthcare. So it's significant. I think these 5 are really the domains of high quality. And it's just so that we can be mindful that it's a trade-off all the time. We can't really have, all those things, and it's really how we, there's no absolute equity, isn't there? It's really about how much of something we can have given the resources available. So more about quality on Monday. But when we think about health services as well, it's helpful for us to think about it in 2 different ways. First of all, 3 levels. The micro level, a few of us have come from clinical backgrounds, and so actually we all have, haven't we? I've met you, and so you all now had a chat, and so we're probably familiar with in our professional capacity of interacting in a micro level, which is a patient talking to a nurse, or a patient talking, giving you consultations, taking a drug history. As a clinician taking a history, having that, that's the micro level of the patient interaction. Then we have the meso level, which we have a medium level of the organization. So if the nurse works in the district, health district, or in the hospital, and that's that level. Looking at the micro level explains some of the gives us a picture of our health service, which is very important, but it won't give us the entire picture unless we go through to the middle level and look at things from the organizational perspective. Then it explains why there are, why things in the patient interaction happens the way it happens. It gives us another layer of understanding. Oh, why is the doctor spending 5 minutes with this patient and 10 minutes with the patient. Oh, why is he or she spending 2 minutes only per patient? The reasons are more obvious as we go to the meso level, and that's why it's helpful to look at that in the organization level. And then we can aggregate up, and some of us might be working in the macro level soon for WHO, looking at international comparisons, or most often might be nationally. We might be looking at in the systems perspective, so different hospitals together as a country. And so these three levels complement each other, and that's why we want to look at it in different perspectives. And throughout this course, we will visit some of the concepts that happen in the micro level and then build together a picture in the meso level and the macro level. And then next, we want to consider it from different several perspectives. A lot of us come from a clinical practice background, and because of those reasons, we come into looking at the system as a whole and into health services research. But we must be mindful that we are, part of a bigger picture, and actually clinical medicine, clinical practice only gives one perspective to health services. And there are many other very valuable perspectives, and that's why such as the School of Public Health gives us this sort of space to look at it from a sociology perspective, health economics perspective. And none of these can give us a full picture. All of this complement each other. So that's why in this course we consider it from different perspectives as well. And if you were to do this course in LSHTM, there is actually a session dedicated to history. And actually it's really interesting, and you can think about it for your country, how actually our health services come to be because of historical influences and how the cultural contexts play into it. And that's very fascinating, and not to undermine why things are. We always think it's science because it's scientific, or science-based evidence. Well, actually, if we think about it deeply, how much of it is actually cultural, belief, and also historical. Okay, so I think the outline of today, I want to talk a little bit about these 4 points, mainly. Why health services, why study it, what does it mean by healthcare, and what have we done so far? So just an overview of the improvements of study of health services and the science behind that, and the key concepts. Okay, so why study health services? You probably all know, you've probably got your own ideas of why you study health services, but essentially it's really important, isn't it, to people's lives. If you ask anybody in a survey on what's the one most important thing in their life, is probably health. It's not money, it's not success, it's health. Without health, it's really the basis to a lot of things. A lot of people's fundamental goodwill. The public think health is really important. Secondly, because of that, it's also very much in the political agenda. At least in many countries, it can win elections. Politicians talk about health a lot because of its sheer importance. It's spectrum. There are some societies who purely everything is driven by health, but essentially, sometime in all of our lives, we might feel that we will come into contact with health services and healthcare, and so that's, I think, fundamentally very important. If we compare it to many other important sectors of the economy, there is so much research in health, isn't there? We've got, if you compare it to the energy sector, education sector, actually we're a well-researched area, because I think it just reflects the fundamental importance in people's lives. And we know that overall we're about public health, and we're about improving people's population's lives. And about a third of all the advances and contributions to current health and improvements through allopathic medicine and health and the systematic efforts of health services probably contributed to a third of the improvement in population health. We still know very little and lots of uncertainty about how we define good quality and what good quality healthcare looks like, and what is good and what is effective and what is efficient. We don't know about these aspects for so many of our aspects of our healthcare. We're still thinking about setting outcomes, setting standards. How should we measure it against? How do we make it better? Lots of uncertainty, and I think that's why we want to continue to study it. And also, very importantly, I think this dialogue, this discourse about the public's relationship with the health services and with actors in the health services, healthcare professionals, namely the doctor. It used to be that doctor says it all, isn't it? oh, the doctor told me so. However, this dialogue is rapidly changing. We've got patients, I'm going to talk about it later on today, but patients becoming more and more informed, and they've got citizens' rights. They are consumers, and they're purchasing health as well in this day and age. And how that rhetoric has changed the accountability of our health services. We are spending, governments are spending money, people are spending money, resources are being poured in, so we need to make it accountable. And importantly, I think the last two, it's a large employer of staff, at least in the NHS. I think at one point, it was like the third or fourth largest employer in the world. The National Health Service was second to the Indian Army or the People's Republic of China's Army, or etc. on the Indian Railway. So there are, at least in certain countries, huge employers with lots of union power, perhaps, and an industry in itself. And we talked about sustainability, climate change, and carbon it can generate. And also, not to forget the powerful medical industrial complex, the private sector that also works in dynamics with the health services. So lots of different players there, lots of different reasons. So what do we mean by health services and healthcare? I mean, this module is dedicated to it. And I think we know that in the School of Public Health, health as a wide concept, the social determinants makes it very broad. We've got health promotion, health prevention, smoking cessation activities, where we see in the community, and that's a form of healthcare as well, all the way to prevention, and then cure, where we traditionally think about the doctor in the white coat and scrubs, ER scenes, or we think about treatment, hospitals, cure, treatment, all the way to now more and more important with the increased life expectancy, the elderly and the super elderly, into more rehabilitation and care. Rehabilitation in terms of not necessarily curative treatments, but prolonging life, maintaining quality of life, health status, maintaining independence, and that's also a huge spectrum of activities, all the way to custody. What do we mean custody? Mental health, psychiatric services, custodial care. So huge different areas of society and coordinated efforts for health. And then it's also important to mention that the boundary is sometimes not clear cut. What do you mean by that? There are direct activities where we know very clearly these are health because they take place in a certain setting, in a hospital or in a general practice. The nurse gives an immunization, so these are very, very direct activities. But we know that there are also indirect activities, such as if you take health in the broadest sense, everything, transport, housing. I'm in government, working currently in government, and we're looking at things like active transport. These all improve the health of populations, but they're indirect activities, and I think it's important for us to sort of keep the scope narrow. And so I think when we mention health services in this module on healthcare, we are talking about the direct activities, but the scope is very large, and the boundaries are not clear cut. And I think we just need to be mindful of that. When does custody? Where's the boundary between a custodial sentence where you're in jail and a mental health facility where you are in a secured environment? That boundary is not clear cut, is it? There is a study somewhere that suggested that 75% of inmates, jail inmates, have a dual diagnosis of a mental health condition. So, society decides these things, but where does the line fall? So, just to be mindful that it is not clear cut. So, how have improvements been achieved? I think this is looking at how science has contributed to the improvement of healthcare, health services. And Arnold Redman, who was the director of the New England Journal of Medicine, in the late 80s, wrote a really helpful article of what has happened to date at the time. And he describes three eras of coordinated efforts in healthcare. And he was describing an American, but I think the American system, but I think you know a lot of the allopathic medicine followed that in many Western countries, and probably similar to Japan, but you can probably plot your own. But he called it that, you know, after the war, and from the 1950s onwards, there was an era of expansion of allopathic medicine where, you know, antibiotics was discovered. You can control infectious diseases. The sky was the limit, and there was just so many new ways of treatment, and people thought, you know, we've really cracked it. We can cure, you know, we can cure all these diseases and eliminate ill health. And so this was the era of expansion where there were lots of new discoveries, lots of new cure. And then sometime in the late 1960s, people realized that costs were soaring, and actually, this is not the limit. There was difficulty in, you know, in making sure things were not, we were keeping on, you know, there was more and more treatments coming about, and actually more and more money was spent in health, and governments were getting more concerned, and so that was the era of cost containment, and lots of, you know, financial means of constraining health was healthcare expenditure was really the focus. So from the 1970s was the era of cost containment. And initially it worked, you know, you could use financial incentives and to really just curb activity. But actually, eventually, you know, the clever players in the system outplayed it, and actually it didn't really work. You know, healthcare was still soaring, costs were still rising. And it's not, we can't just keep expanding indefinitely, and I think governments knew that. And then came the era from the 90s onwards, an era of assessment and accountability, and we are in this era of assessment and accountability. And what do we mean by that? Essentially, we are looking at why we're doing things, how we're doing things, because not only we can't just contain costs on its own, we need to know what's effective, what's efficient, so we can, you know, together work out an accountable way. And so therefore we are now in the era of cost accountability and assessment, and this was helpful, and when he penned this down, and I think it's just quite helpful for us to see how coordinating care of science and understanding and researching health services has helped us looking into this. Now, we talked about the science of improving health, you know, researching and understanding health services and improving this. In this great picture of what drives healthcare policy, I just want us to be mindful that we are in the scientific evidence far right area. And actually, there are so many players in this sphere. If you think about the healthcare policymakers, we think, oh, it should be, you know, science-based evidence-driven policy. You know, that's us wishing that. But we must be mindful that actually there are many players in this world, and we are part of the environmental turbulence, we call it. But actually, it's more what we want to aim for is probably evidence, scientific evidence-informed policymaking, because, or influence, in fact, influence policymaking. Because look at all the influencers in the system. We've got the healthcare professionals and the important trade unions, the clinicians. Might, you know, rightfully, all these players have a place in influencing the health system. We've got the central government, we've got public and mass media's interests, and you only need to you know, think about a contention in closing down a hospital. I mean, at least in England a few years ago, when they wanted to close an A&E department because it was not effective. All the public, the media attention, and the politicians rising up against it, and that dynamics, it's very real. And we've got the powerful players of industry, you know, mindful that these are all rightfully there. You know, even though we question their motives, and, you know, is it for profit? Are they got the patient in mind? You know, it's a necessary dialogue, but they're all rightfully there, and it is the dynamics, isn't it, and a balance of the different players and powers. So, okay, and importantly, what are the key concepts? I think if we think about from how our health system works, this is really key, a key slide. There is always a struggle for influence and control, and I don't know very much about the Japan system. But if I were to go into a country where I know nothing about anything of the healthcare system, I want to know these three key dynamics and interplay. First of all, I want to understand how does the dynamics work between clinicians' autonomy. It's very crucial that many of us come from a clinical background, that professionals have an autonomy, a degree of autonomy. I mean, 50 years ago, professional autonomy was the center. Healthcare just ran with what the doctor or the nurse said. And that was how it was. Now this is changing. How does it work in Japan? How does it work in your country? Do doctors say, and increasingly, there is a spectrum now. There's a certain degree of autonomy it's important for a professional to practice healthcare. But yet also increasingly, there's an accountability to this autonomy. It's only in a capacity way, in a limited way. Why is that? Because we have some corporate rationalizers. We're talking about being accountable to the system and being in the era of accountability. And what are corporate rationalizers? And we are in this sphere now. Being in researching about health services, being in the school of public health, we have now all collectively the corporate rationalizers, and it's an awful name, isn't it? But what it means essentially is those of us looking at the system as a whole, thinking about the populations. When you are the doctor, the clinician, you are thinking about the patient in front of you, and rightly so. If you were the patient, you want your doctor to be thinking about you only. You don't want the doctor to be thinking about other people. If I was ill, I want the best treatment immediately now, whether or not it costs lots. Obviously, that's normal, and so you want the doctor to be thinking about yourself. But then there are also the importance to keep everything accountable and assessing the era of managing, studying, looking at populations, looking at the system as a whole, and thinking about populations as a whole when we know that, what's the most effective way, what's the best treatment. And so those are corporate rationalizers. And then lastly, the public. And this is rapidly changing as well. We talk about, we're going to talk about the role of the consumer, the public, the patient. And so this struggle for influence and control is really what underpins a lot of the challenges and the things we're looking at in healthcare. And when we study health services, if we know the dynamics between these three and we understand it, that's when we begin to see the complexities of it all. And that's when we are being able to work around it. All these three have a role. We just don't want one to be overtaking another, and it's about being in balance with one another. And I think, also importantly to be mindful of is also the market system and the command and control system. And we've got one end. We think of the market system of healthcare. What country comes to mind? We say markets, healthcare market. What's a very private-driven market? Maybe America, United States. If we think maybe, someone say maybe. About what percentage of states is private care? How do people know? Out the top of their head, about 50%, actually 50%, and the other 50% is actually still publicly funded. So we've got the Medicare and Medicaid. So around that figure. So actually we think about the market. So it's a spectrum, isn't it? It's not, so there's a very, very market-driven model of healthcare, which is the states. But only then, there's still quite a lot of publicly funded money. And then when you think about a very public system, probably you think about the NHS, the National Health Service in England, 90% the activities are publicly funded. But most importantly, we want to think about the three players, three different key aspects of healthcare. Who are the payers? Who pay? So who funds healthcare? It has to come from something. Taxpayers, donors. A lot of lower middle income countries have wealthy donors. Insurance subscribers. And who are these people? Are these the employers or the employees or both perhaps? Then we want to know who purchases the services. And many countries split the provision and and the purchasers. So sometimes it's the government, the local authorities buy these services. Insurance companies, very powerful, decides which hospitals in America, you can only go to this hospital and have this service, very powerful companies. Sick funds, which is a lot of European countries call their social insurance schemes. Primary care practices, sometimes the structures are bought by the generalists. They purchase the more specialist healthcare. And also people, out-of-pocket payments, can buy services. If you see a private doctor, you pay them out of your pocket. Providers, who are these people? Are they publicly owned, privately owned? And in every system, in every country, we want to consider these aspects. So, the outline of the health services module at an LSHTM over one term looks at all these aspects. And it's helpful for us to organize health services into our inputs, our processes, and outcomes. And I think I will explain more about each of these aspects in a bit, but this is over 10 weeks. So throughout these next week we're together, I've got a condensed version for us. So we're going to look at certain aspects, also through inputs, processes, and outcomes. For a complete picture, I think it's important to consider these aspects of how the coordinate efforts of health services come together. And so today, I'm going to start off with some inputs in our next talk, with formal and lay care, a little bit about diseases and medical knowledge, a little bit about healthcare professionals. Hopefully we already covered some of those things. And then tomorrow, we're going to look at a little bit of through a seminar, users of healthcare and the staff-patient interactions, a little bit of interactive time together. On Friday, we'll look at need, demand, and use through a talk. So looking at the activities of healthcare and how those relationships work, a bit more of a microscope dive into these activities that we consider to be direct activities of healthcare. And then on Monday and Tuesday, looking at quality of health services, what it means by quality in a little bit more detail, and also how do we measure outcomes, what are the challenges, and my own specific interest is looking at measuring effectiveness with patient-reported outcome measures and how we can use PROMs. And so I'll talk a little bit about that as well. So this is the plan for the week together. How are we doing for time? Okay, so before I move on to the inputs of health services with my second talk, should we have a little bit of a coffee, like a 5-10 minute break for coffee for something, and then we can excuse me, we can reconvene after that. All right, thank you.